is just a reminder of where a lot of our resources are kept, which is in our Futures NHS webpage. And if you've been in there, there's it's like an Aladdin's cave of things that are helpful resources to help us understand how we can embed a culture of research. So obviously this is our mental health theme, and we're also going to be focusing on health inequalities and quality improvement. And you can click on any of these sections in the Futures webpage to find lots of different resources to help you. Next slide. Now I'm handing over now to our mental health expert who is leading on this webinar, basically, Anthony, who is our clinical matron that's supported a lot of the work in our toolkit, as well as lots of other different things as well. So I'm going to hand over to you, Anthony, to introduce yourself and talk about what you're doing in your organisation to embed a culture of research.
Thank you very much, Nicola. I'm delighted to be here to talk and to share some of the things that we have been doing. So I'm Anthony Jemmott. I'm the community matron for Camden Division, North London Foundation Trust. And next slide, please. Just to whiz you through quickly my journey. So my curiosity, my introduction to research really started at King's College London when I embarked on a undergraduate degree in medical biochemistry. And, you know, it will be not good of me to mention key person here, Professor Edbringer, who was my tutor, who really sort of brought me to the frontier of science and, you know, really introduced me to the idea of the refutability of the null hypothesis and the whole Popperian stuff theory. I did a final year project looking at inducible nitric oxide synthase, and people like Professor Badoon and Professor Pearson also. So they really introduced me to the idea of research and the importance of it. Having completed that, I then moved on to do my nursing training at St. Bartholomew School of Nursing and Midwifery. And again, that quality of research being embedded there, that seed being sown, I sort of took that to a different level because, as we know, nursing, the research in nursing is quite specific and it's very different, but similar also. And there are a lot of crossovers. So it's looking, what I did, I just transported that knowledge, that gain, that King's College London, and look at that for evidencing in terms of clinical practice, because that's one of the things that keep coming up when I was training as a nurse. Then after completing my training, I started to work where I am now, and I met Professor Nolan, who now is our associate director or director of nursing for standards and safety. And she, again, helped me and supported me in introducing that idea as a non-medical prescriber and evidencing what I was doing and sort of taking it to a different level, really encouraging me to take up audit, take up research, and to look at that in a critical way and a curious way, and keeping that clinical curiosity going. So that ended up, we had a poster that we had put together looking at physical health and service users with serious mental illness. We did put a poster, an abstract for the European Psychiatric Congress, which took place in Warsaw, Poland, and it was accepted. And we were called to talk about the results that we received on that. So that took me again to within the trust. I got involved with the research group within the trust. Again, being curious, no one called me, but you know, just that seed that was planted and the people who supported me, I thought that I needed to continue on this journey, even in the role as a matron. So I got to be PIs for a number of projects, which the research team will tell you about later on. And that really, again, opened up for me a lot of doors, and it also helped me to connect and to synergize the clinical area with the research area, because I think that's a big gap we have within nursing and midwifery. We tend to sort of operate in silos, but we need to come together. So what I did, I opened up the clinical area, that's the clozapine clinics in Camden, as a placement area using the education model, bringing in the research team, getting them to do a lot of audits, getting them to educate us in terms of what they do and how that could benefit service users at the end of the day. Because I think with everything, we need to be cognizant that we are here for service users. And then, as I said, looking at adopting the leadership model and also the education model. You'll hear from an MSc student later on, Imogen, who that again managed to open up the clinical area for a placement for MSc students from University College London Hospital, where they come and they would remain for about 1 year. They would support research. I think one of the key things to remember within the room as leaders is to bring the younger ones with us, the newly qualified nurses, the midwives, the MSc students, to get them on board, to influence that research culture and get it embedded within the clinical area. And it's important we do look after the younger ones, because at the end of the day, they will be our carers in the future. So I think it's really important to embed that culture. And what we had a paper that was accepted recently for publication in the British Journal of Mental Health Nursing that I'm really excited about. Imogen was able to review that paper, who will be speaking afterwards and will be as an author on that paper. So that's a quick journey through, and I'll just show you in the other slides how I was able to embed the culture of research using my the matron's toolkit and the matron's handbook. If we just move on to the next slide, please. Yeah, so this is my work plan that I put together, and this is an example of how you could embed research and the research culture. So all of the stuff on the leadership, the research culture, everything was taken from the matron's handbook. And what I have done, I have given examples here on how I am meeting those competencies. So all this was competencies from the matron handbook, which inevitably was my job description. And I have mapped this on my work plan. And this is my tool for evaluation, for revalidation. I use it for appraisal, supervision. So it's a good way in which we can help us to stay focused and to encourage that learning. Just the next slide, I'll move on to quickly. And that's another example in terms of, and giving examples in terms of being principal investigator for other projects and stuff like that. So that's it from me in terms of how we can actually embed research within our job description and within our business as usual as a community matron. Don't need to do anything differently because we're supposed to be doing that anyway. It's part of our job description as matrons. Thank you very much.
Love to hear that, Anthony. Absolutely brilliant. You might find something similar to this on our Futures webpage as well. If you want to think, well, how am I going to add research into my job plan, because it's very bespoke, very different for everybody's, mental health matrons are definitely different to acute matrons. Or so, you can bespoke this for yourself, but yeah, absolutely. Anthony is just a pillar of brilliant embedding a research culture. So thanks, Anthony. Next slide, please. I think we have Imogen, who has been working with Anthony at North London. Do you want to tell us about what you've been doing in the trust, Imogen?
Yeah, hi everyone. So I'm Imogen. If I could have the next slide, please. I'm a master's student at UCL. So I do placement with Anthony under his supervision 1 day a week. And obviously this is quite a brief time to be within the service, but as you've seen, Anthony, his curiosity is infectious. So the research aspect, which he's been discussing, I've been getting lots of experience that every time that I'm in. So if we just go through this slide, I'll quickly run through all the points. So yeah, I'm halfway through my master's at this point. So alongside doing lectures, I'm learning clinical and research skills from this placement. And previous research experience, I didn't have much. I only have experience from my undergrad. So coming in here, I've already started to learn a lot and advance these skills, thanks to Anthony's help and thanks to the team. And I'll talk a bit more about this. So if we could have the next slide, please. You can just click through everything, sorry, yeah. So at the minute, I'm currently working on a study which Anthony did an audit around the clozapine clinic. And we've been working on writing this up and getting it ready for publication. And as Anthony said, we've been accepted. So coming in from an undergrad, I thought to get published, you had to have loads of research experience and you had to have spent months and months and months writing and revising. But Anthony allowed me kind of this experience straight away of assisting. And that's a really not easy, but it's a lower way to get your name on a published article, which is great experience if you ever want to in future go into research or become more involved in it. So just by editing and adding in some paragraphs, I was able to get my name on this piece of work and also see how the research process had been done throughout and how a proper article is written up. Next slide, please. So these are some things I've learned so far to quickly summarize of how research works in the real world. So there are several hurdles you need to go over and under to get research completed, but your supervisors will be extremely helpful. And also it's about accessing the resources you're given. So for data access, you might need to communicate with groups of people, get permission, get ethical permission. And these are all things that you can go to higher up people and get guided through. So I've actually started to get involved with another research team, which Anthony introduced me to, and I'm just helping them screen participants. And by doing that, I can also have another thing to add to my CV regarding research. So if in future I ever do want to start doing independent research, I would have the ability to do this. Yeah, and currently we're at the stage of reviewing our submission for publication, and hopefully very soon that will be published. And I might even have the opportunity to go to a conference to talk about this publication, which is very exciting. Next slide, please. So yeah, as I've spoken about, I've received lots of support. And I'd say the main way that students can get involved or people who have just started out within the field is by asking. I was very lucky that I was given a supervisor who presented these opportunities to me. But there are actually so many things going on within every service that if you ask, they always need help. They always need someone to transcribe a study or someone to help screen participants. And just by doing that, you can start reaching your way into the field, which leads to just more and more opportunities. Next slide, please. So it's really exciting to see the impact you can have. So just starting out, I can see how becoming involved at this level will help my progress within the field. Also at a service level, the audits we're doing will hopefully help future service users improve the quality of care that we're giving. And at a wider level, the research that we're looking into could really be helpful to all services because it's relevant to clinical practice rather than relevant to theory. It's kind of how can we help the people that you're working with and you yourself do your job better. Okay, next slide. Okay, that's all I had to discuss today, but the overall emphasis was that there is always something to get involved with, and I'm really excited that I've started to become more involved on the research front, and I hope that more people also become involved too. Thank you very much.
That's absolutely brilliant. I just love how that is simple idea, and it's working, and like you say, more and more research will be created from that as well. So and interested as well in your title, honorary clinical support worker, and how it'd be another question and answer session, and Anthony, you might want to answer this in the chat about how you've practically set that up and things. I'm sure other leaders would be interested in how they might mirror that model. So brilliant. Thank you so much,
Yep.
Imogen. So next slide. Who have we got next? Now we're going to hear from the research team. Are they there? Hello?
I'm here.
Hiya.
Hi.
Over to you.
Thank you. My name's Elle, and my colleague Emma is in the chat today. She'll be speaking just after me, and we're clinical researchers within the research and delivery team in the North London NHS Foundation Trust. I've seen some things in the chat on how people can get involved. I'm happy for you to reach out to me or Emma, but my colleague Emma will be speaking more on how clinicians and staff can get involved at the end of this little slide. So our role mainly is to recruit participants for studies being run across the UK from secondary mental health care and deliver interventions and so forth. So I'm sure you all know research is incredibly important, not just in North London, but across most NHS trusts. So many trusts have it included in their strategy and their aims to embed research right into clinical practice. So it really is crucial that clinicians are involved in research, especially in increasing access and including EDI, because it just increases opportunities for service users and clinicians to firstly take part in research, but it helps us to kind of involve the hard to reach populations, and it increases diversity in research. So we need this kind of diverse data to develop evidence-based interventions and services that represent the populations that they actually serve. So for example, during COVID, the research that we were doing to develop interventions were based on the available data that was quite heavily skewed to people predominantly from white backgrounds and didn't really fully capture ethnicities outside of this, meaning that the interventions were best received by the populations that the data came from. So that's quite a limitation that we have across the mental health studies at the moment. So the need for staff support is really vital. So to get this kind of data, regardless of role, with like all clinical staff and leadership to get involved. So where we've made great connections with clinical staff, we've seen a huge boost to recruitment in the studies. So for example, Anthony's been a vital link with the clozapine clinics and other services he works in to run research studies. So for people who want to get involved or are looking to get involved in any way, you don't necessarily need to be running research projects like Anthony or be heavily involved. It's just extremely helpful, even if you're just acting as a link or a contact to the services to enable our research to take place. So we're going to speak a little bit about what kind of studies we're running in the clozapine clinics. So we've just recently closed a staff questionnaire study called UK Reach. And that's a long-term study currently collecting data to help staff retention after COVID. And we were particularly looking at minority populations because they had the highest attrition rates. So Anthony was the PI for the study, and we'll explain more about what a principal investigator involves later on. But what he really did was help promote awareness of the study so that staff could take part. And Emma's just going to take over from here.
Hi. So we also do questionnaire studies, and we've done a lot in clozapine clinics, thanks to Anthony as well. So we've done studies that look at things like gambling-related harm, physical activity, and aggressive behaviour. And these are really great studies because they're quite short in terms of the questionnaire length for participants, but they also don't require much input from staff. So, for example, in clozapine clinics, we recruit from waiting rooms whilst people are waiting for or in between their kind of appointments. But we do need the staff to allow us, to allow us access to those waiting rooms and clinics. So Anthony's been a really key person enabling us to do so. We've also done intervention studies. For example, Diamonds is a study that is for those with severe mental illness and type 2 diabetes. And it's an interventional study to try and help them manage these conditions better together. So we were given a caseload from a clozapine clinic. We were then able to find suitable patients from their caseload and then give them the opportunity to enroll in the trial. So without those links with those staff members, we wouldn't have been able to give those patients that opportunity. And for those staff members, it didn't require any input from them. So that's just an example of how you can be involved and help promote research happening within your trust without kind of impacting your workload too much. In terms of different types of involvement, as you mentioned, Anthony has been a principal investigator for a number of our studies. So this is a role where someone is the responsible clinician leading a study at a particular site, and involvement varies depending on the study complexity. There are also associate PIs, which are clinicians that can help support the main principal investigator, and there are training schemes to do this. We've also had people trained to be interventionists on studies, where they are trained and they deliver the interventions to participants in the trial, such as a new therapy being tested. And we have people support with recruitment, like Imogen was saying. People may do short placements with us, where they can be involved in our team from the recruitment side of things, and that really helps increase their experience and enhance their kind of CPD as well. But the easiest, most vital way to be involved is by being a contact with research teams in your trust and providing those connections initially. And if you can be more involved, then it can lead to more things, such as being a PI or being more heavily involved in studies. But being that initial contact is really crucial so that we can increase the opportunity for patients within the trust that have access to research. In terms of training, there's things like the National Institute for Health Research. They have loads of free training on their website, and you can sign up for free. And within this website, they have a training called Good Clinical Practice, or GCP. And this is quite often a key piece of training that you would need to take part in studies. It's a really good qualification to have. And then there's also local trust training with your research and delivery team that you can do. For example, we have an office called Knocklaw that support a lot of research studies across London, but wherever you are in the UK, there will be offices and teams within your trust as well who can help support you. Thank you.
Thank you so much. That's brilliant. There is a question in the chat, but I am conscious of time, so I wonder if you would be able to answer the question in the chat, if that's all right. It's about how engaging marginalised and underserved groups, which is an absolutely key priority. But we're also moving on now to an EDI section. So if you could answer that question in the chat, that'd be really helpful. Thank you so much for that presentation. It just shows how joining clinical and research together enables it to work for the patients that come through our services, doesn't it? So thanks so much for that. Next slide, please, Chris. Okay, can I introduce Samina now, who's going to talk us through her slides? Thanks, Samina.
Yeah, hi. So I'm going to very quickly go through the EDI and addressing health inequalities at North London Foundation Trust, and it's great that we've had a few presenters talking about their research work. So next slide, please. So at our trust, EDI and health inequalities is quite important, and it does feed into the board. We have a number of work streams, and the one key area is service users and health inequalities, and we make sure that the patient's voice and service users' voice and the voluntary sector is part of that, and working closely with our research and development team actually to start working closely with us to create evidence-based approaches, for example, in our patient carers race equality framework work as well. So next slide, please. So why is it important to our trust? Well, we do have an EDI strategy, and with some priority areas. And as you can see, with priority 1 and 2, it's really important that we have better health outcomes, regardless of which communities people come from, and that patients, when they're in our care, that they receive the best care and the experience. However, for some groups, that's not always the case, and we're not hearing of them through our traditional routes. So research is really key to that, and it's really great to see the work that's happening. Next slide. So it very ties into we are an anti-racist organisation, and we have 3 priorities in terms of making sure it's prioritised, that we understand and grow, and that's very much linked to how research and lived experience and our data actually informs the work that we're doing, and that we actually tackle inequalities and review if things are not working, why are we still doing them. So I think research is very key to make sure interventions around addressing health inequalities take place. Next slide, please. One of the reports that was done a few years ago was the State of Inequalities report, and that was as the new data around the census came out, and it was an opportunity for people in my team to actually do some mapping, and there were some inequalities that were found against these priority areas. And these priority areas, when you're looking at mental health, isn't rocket science. We know that some groups do not get the same outcomes across these things. If we're thinking about communication and how people are accessing services, whether they've got a language barrier or disability, and how we're using equality monitoring to actually make a service change. Next slide, please. So you've all would have heard of Core 20+5, and we know when we're thinking from a mental health perspective, not only is severe mental health a +5 area, we know a lot of people with severe mental health will have comorbidities and some of the other +5 conditions, and many of our populations that are living in the most deprived areas within the country. And we know for certain people, particularly under 75, the death rates are high for things like liver disease, respiratory, cardiovascular, and cancer. So it's very key that we have an evidence base and a research focus on inequalities and increasing that. Next slide, please. So just to focus on severe mental health, so if we look at our ICB and ICS area, there is information there in terms of who has a severe mental illness, whether that's by ethnicity, which boroughs, and next slide in terms of age, as well in terms of the disease areas, and as well, next slide, in terms of gender. So language and gender. So a lot of this should really be informing research that we do in clinical areas in terms of who are we talking about, and what do these added layers of inequalities and communication difficulties actually hinder their recovery or access to treatment. Next slide, please. Yeah, this just talks about looking at those severe mental health against the sex of our population as well. Next slide. So this just gives us an example of how we're working internally to look at physical health needs and the groups that are impacted. Particular focus is on ethnicity, learning disabilities and autism, to really improve those outcomes. And there's a lot of interventions, but really adding that research focus can really bring a project or a piece of work to life. So I'm here today just to sort of encourage and set the scene, really, in terms of make sure that health inequalities is factored into research. And we heard about that earlier with the work that Kim and is it Helen? Sorry, I think I got your name. Emma were doing in our trust. So really keeping that focus, because our populations are quite diverse as well. So we really need to make sure that our research actually impacts all our population groups. Thank you.
Oh, that's really excellent. Thank you so much for that. It's so nice to kind of see that the clinical and research worlds with regards to inclusion are coming together. It is so needed. And yeah, I'm sure there'll be more magic that will come from your organization around this. And there are a few links that a few people have popped in the chat around that inclusion, including the REN project, Research Engagement Network project, which is NHS England funded. And there's within that Futures webpage, there's loads and loads of different tools that when we've been working with voluntary community faith, social enterprise organisations around what are those barriers to getting involved with research and getting involved with health as well. You know, there's loads of different things, and it's really worth a look around what's happening in your patch, but also what's happening across the rest of the country, because you know you might actually be able to pick up some top tips from what's happening in other parts of the country. So thank you very much for that. It's really important. So have we got Selena now in the house? Selena, are you there?
Yeah, I'm here. Apologies, I was just looking at the spelling of my name. It's a classic.
Sorry.
It's all right. It's a classic one. I always giggle to myself. It's okay.
So welcome. Do you want to introduce yourself? And
Yeah.
I think, are you going to do the presentation, or are we going to do a bit of a chat around dialogue plus care plans? How do you want to run?
I think I was just going to do a talk. Was that correct? Or
yeah, just because we've only got 5 minutes, so hopefully is that all right? Brilliant.
Don't worry. I'm just So my name is Selena. I'm the Dialogue Plus lead for practice education lead for North London Foundation Trust, and I have lived experience. I deliver Dialogue Plus training, but also the other part of mine is to share Dialogue Plus with service users and carers. And I think one of the things I wanted to share, just to bring all the threads from all the colleagues that have spoken already, is when we talk about research, it's really important to either have people with lived experience not just taking part in the research, but actually being the ones who are doing the research. Because we often talk about how do we get in touch with the communities that are not coming to our meetings or to our forums, or how can we support health inequalities. But actually, if you look at it and you bring people with lived experience who are actually undertaking the research, the engagement has always been better. And that has been my experience in doing Dialogue Plus and supporting our service users to understand the research around Dialogue Plus, why it came to being, and also why the NHS are now implementing it as a care planning tool. And they get it when it's explained to them from using a lived experience lens. And when I've done this, often service users have said, you know, you've kind of explained it in 5 minutes, but my key worker couldn't explain it to me in 45 minutes. And a lot of it is not because they couldn't, but just because the lived experience lens looks at all sorts of things. So it looks at understanding that about re-traumatizing someone, so not kind of being in the present. It also looks at the lens looks at using your lived experience, so sharing your lived experience with someone to make them feel comfortable in being able to trust you, to be able to share the vulnerabilities. Often we get to meet our key workers, but we don't know them. yet we're supposed to be very vulnerable and open with them. So I think the one thing I would say about research is it's really important that people who are actually doing the research, to have people with explicit lived experience to undertake that research, actually will help with bridging that gap around inequalities that certain communities feel. And I think that's something that I think I am trying to encourage more of when I'm trying to think of a research project to actually undertake. The first thing is how can I get service users and carers to actually be the ones to undertake the research, and then to bring it all together from beginning to end, and not just to be part of the research in the sense of the group that we're going to interview, but actually about the whole process. That is what I had to say. I mean, I did have a few slides. I've kind of gone off script, but one of the things I think is really important around care planning and understanding all the research that's out there around trauma-informed approach in care, and around the research around care planning and Dialogue Plus, is the fact that we have to empower not only our service users and staff and carers, but also help build safe relationships so that people feel that they can trust what they're actually doing. And I think that's really important. And I think research lends itself to that, but I was very hard pushed to find research that was undertaken with the lived experience lens, looking at how care planning has moved on from when Dialogue Plus has been introduced now for nearly 8 years. So it would be really interesting, because one of the things that I'm thinking of doing a research project to see how it's actually working as a care plan. I think that's the next step in my mind to help people to understand, and service users and carers, whether it's actually working as a care plan. Because it originally wasn't devised as a care plan. So on the video, sorry, if you can just go back one slide, there's a video, the second video, if anyone gets an opportunity to watch it, you will see that it wasn't originally designed as a care planning tool. It was designed as a quality of life tool. But then NHS England wanted to bring the two tools together, which is the assessment and the care planning. And so we developed Dialogue Plus, the care planning tool. So it's really important to understand that care planning part of Dialogue Plus. And I think the research will help us to embed it and understand it better. The next one, sorry. And then I think, the next one, sorry. Next one. So in this one, the trauma-informed care, thank you. The one after this one, sorry. Next one. Right. So it's this one. So it's really important to understand. So in any research, what I kind of look for is, if I want to get involved in research or I want to undertake research, it's really important that we kind of think about these elements using the trauma-informed lens, about, you know, what kind of agreements are in place. Is it feeling safe? Do we need to look at how do we build trust? Is there choice available? You know, is there a conversation being had about how we're going to work together? Is everyone in the space feeling empowered and supported? And how can we support everyone's voice to be heard? And I think sometimes when I've looked at some research, sometimes about the planning and the delivering of the research, there's always a framework or a parameter that's been set. So say, for instance, in one research that I looked at, that this has got nothing to do with Dialogue Plus, but a different type of research in the Odyssey trial that was looking at peer open dialogue practice. The parameters was that English had to be their first spoken language. Now, considering that we work with lots of diverse communities, that actually meant that a lot of people would be excluded from that research. So for me, I think when we do research, we do need to look at how can we make it inclusive rather than trying to fit the parameter in what the outcome that we want it to be. So I slightly digress there, but I think it's just really important that the EDI lens, the research lens, also the inclusion and the actually service users and carers actually taking part in the whole process is really important. I will leave it there. Sorry, I went a bit off piece. This serves me right for not coming to the pre-meeting, so apologies.
No, it's been really, really interesting and so important as well. That lived experience is so important. And I'm sure there's people on the call today, like Joe Cooper, who's just put a comment in the chat, Paul even, that could also potentially develop a research study around the Dialogue Plus thing. So let's have a conversation about that maybe in the future. But thanks, Selena.
Thank you very much.
Thank you. Move on to the next presenter, if that's all right. Handing over to Lois.
Thank you. Next slide, please. Hi, so it's been a very diverse afternoon listening to lots and lots of different types of research. And I think one of the things that comes across is that we're all individuals and our client group are individuals. And so there are so many different ways to approach this. I think what I've come to talk about this afternoon is about our quality improvement programs. So we have a program called a Director of Nursing Fellowships that is open to Band 5 and Band 6 nurses and AHPs who can take part for a year in a project, so they can develop a project in quality improvement within their work area. And they have 1 day a week off for 12 months, and then they present the project at the end of the 12 months. So as part of that project, they are given 3 different mentors. So they have a clinical mentor, so that's a matron, a ward manager, it can be a director of nursing as high as that. And then we have an academic mentor who has an MSc or a PhD and offers any academic advice around the things that they need for their projects. And then they have somebody from the quality improvement team who also offers mentorship. So they can have up to 3 lots of supervision per month as per their request. The aim is that they develop a project within their area. And the ones that have been developed specifically around mental health that I've taken part in have been things around improving clinical outcomes for people in specialist intensive care units, so people who are having one-to-ones, and the patients have fed back that they never felt they got their one-to-ones and it was always with a different person. And the nurses said that the patients didn't always want to take part in their one-to-ones. So the nurse went ahead and interviewed both parties and then wrote up the research at the end. Had somebody in crisis looking across their pathways with patients dissatisfied, so got their patient outcome work out. And it identified that patients didn't like being seen by a different person every time and having to retell their stories. So part of that work was looking at how they could develop information that was shared properly to the next person going in, and where possible to get the same member of staff going in. So these are very clinically based issues. And the final one I took part in last year was somebody who wanted to introduce discussions around chemsex with patients who were coming into our units, because they were identifying a high number of male patients who were coming in involved in drugs, but nobody was asking them about the drugs and specifically around the chemsex elements of it. That turned out to be the most interesting project because the majority of people were very concerned about talking about those sorts of things. So their learning outcomes with staff groups and patients to actually make it acceptable to talk about were really, really important. So the projects end with them doing, they write up a piece for a journal, they then present it to a journal, and then they have an awards day where they just meet together and celebrate their projects at the end. It's not awards in the sense that somebody's better than anyone else. All the projects are awarded a completion, and that work is valued within the organisation. And I think for a lot of individuals, it's about that process of taking part. So for us, we encourage people to get involved in focus groups, to take part in research that junior doctors are doing, and to take the lead in a research project, and to take part in clinical trials. Because unless you've actually taken part in research, you can't begin to design it. Because actually you don't know what it feels like to be a participant, and it makes it much harder to engage people at that level. Next slide, please. So for me, research is part of our everyday working lives. Our ownership of it adds to the process, and working on your own strengths to build and encourage us to bring about change. We all want to see change. We're all spending every day talking about it and saying we could do this better, but never finding the time to do that. And I think if you can encourage from your healthcare assistants up to your chief exec to actually encompass that change, that's the only way that it will move forward. I think for matrons, you have a unique role to encompass change and drive forward new ideas. And I think by empowering staff, and we've seen that for our band 5s and 6s, and some of them are newly qualified, come through and they go, wow, I didn't know we could do this. I actually feel I have some autonomy and somebody's actually listening to me. And actually what I've achieved has got outcomes. And it's really important to lead, publish and promote that work. Thank you.
Brilliant. Honestly, I think that it's just an absolutely perfect way of, we're always trying to continuously improve. We're always doing quality improvements in health and care, aren't we? And that model that has been set up there with the 3 supervisors just seems like pure gold. And you know, you do 20 throughout the year, don't you? But you know, if we're thinking about our own organisations, you just start off with 1. Maybe you know, get those 3 supervisors, and if you haven't got academics in your trust, you might have a research delivery team, but obviously you've got your local universities as well that might be able to supervise. But I'm sure you've got a plethora of people, like Lois says, that have done masters and PhDs, and it might be hidden, but you know, find them, and they could help support these sorts of projects again. Lois is a consultant nurse, and obviously she's a leader. She's not a matron, but she's a leader in her organisation, and he's helping drive this forward. So thank you so much, Lois. That was really, really interesting. Next slide. I think we've got Victoria. Yes, yeah. Welcome, Victoria.
Hi, everyone. Yeah, my name is Victoria Sharman. I'm a practice development lead. This presentation is actually based on when I was working as a clinical matron. So if we can just move on to the next slide, please. My details are there if anybody wants to contact me afterwards for any further information. And just a quick shout out there to the Red for Research campaign that's on the 20th of June this year, supporting everybody around research and all those people that are making research happen. I can see some claps, so good stuff. Let's support that. Next slide, please. So there I am again, wearing red, as in the Red for Research campaign, but getting to the topic. So why did I start using evidence within incident review? So like I said, I was working as a clinical matron at the time, often responsible for looking into things like complaints, DATEX incidents, serious incidents reviews. And I kept noticing going into meetings that, you know, the same learning kept coming up time and time again. It was like we weren't learning from incidents. The same recommendations, the same actions were always there. And I was getting used to kind of, you know, when I was undertaking these investigations, you know, we'd benchmark against what has happened, you know, we'd see an incident and then we'd have a look against, you know, what actually happened compared to what we thought should have happened. And when we were benchmarking, we were using evidence because we were using policies and guidelines. So that was part of it. But when we were coming up with these sort of recommendations and actions for learning, often they were just kind of, remind staff to do this. They weren't necessarily evidence-based. And I started to notice a real gap around that and thinking, well, maybe that's why we keep seeing this same learning kind of cropping up. It was at the same time that the patient safety incident response framework was being launched, and that had real emphasis on kind of learning from incidents, not placing blame on individuals or focusing on individuals, but looking at systemic learning and drawing on that evidence. And I was also thinking at the time, well, I really should be role modeling this. I used to work as a research nurse. I was a part of the NIHR 70 at 70 program as a senior research leader. I really should be sort of role modeling using evidence with it, to inform practice. So that's why I started to use evidence to review my incidents, particularly around making sure the recommendations were evidence-based. Can we move on to the next slide, please? So I'm sure, you're thinking, oh, great idea, but, and these are some of the challenges that you're probably quite familiar with, and if you were to try and sell this to staff, they're too busy, they're not confident to do this. Can we even use evidence? We talk about evidence-based practice, but are we actually allowed to do it to change practice, or do we have to wait for fancy guidelines and sort of publications to come out? And where would I even look to get hold of that information? So these were some of the things that I was hearing from my colleagues when I was trying to sell this to them. Next slide, please. So in terms of can we do it? Yes, we can. We know we can look at evidence and kind of inform practice using it. Kind of the confidence comes from doing it as many times as you can, really, and being supported with others who are confident in using evidence and literature. In terms of where to go, well, we don't need fancy university accounts to access, all these amazing databases. There's a lot of stuff we can access sort of just via the internet, via our kind of NHS kind of things like Open Athens, and our librarians are a fantastic support as well, and often will undertake literature searches for you. So definitely use some of those resources listed there. And obviously, looking at those professional resources that are out there as well. So to do that, next slide, please. So just really, really quick, just a couple of examples of where we used evidence. So we kept seeing time and time again that kind of medication room and fridge temperature recordings just wasn't happening. And we all knew it should, but it wasn't happening. And when we started to kind of explore why this was happening, we did a process map and we realized actually the clinic didn't have any kind of procedures for setting up. They just kind of all did it their own way and got on with it. And when we looked at kind of what the evidence was suggesting, checklists kept coming up, often used in industry, particularly the aviation industry. Checklists to set something up was really well recommended. So we introduced a checklist around that. Other things were around kind of reducing errors within depot long-acting injectable clinics by reducing distractions. So we looked at evidence around how do you do that. And it was great for ward-based kind of examples, but we found, so we took some of those examples and implemented them in a community setting. And again, another example was around physical health monitoring. And we realised, we were screening, but we weren't intervening because staff didn't have the ability to recognise necessarily escalating and deteriorating physical health. So we introduced some work and around sort of the evidence around that. So just a couple of examples there of how kind of, following incidents, how using evidence, then we came up with some really specific recommendations as opposed to just the same old, please do this type reminders. So I think that's probably the end of my presentation. I think the next slide is just in terms of benefits. I have mentioned just a few of them, but I'm very conscious of time. So I'll let you review them in your own time, and then, like I said, any questions, please do get in touch. Thank you.
Thanks, Victoria. That was really good as well. Just really thinking about the practicalities of how matrons and leaders, the things that we have to do in health and care, and thinking about research. People think it's about the PhDs, but actually what has other research that's gone on before that evidence-based practice is what we should be, implementing and doing. So I think that's a real good practical example of how that can work. And obviously now you're in a practice educator role, that you're going to be promoting that across your matrons and leaders, aren't you? So brilliant. Thanks, Victoria. I know that Paul has had to leave. He's chairing another meeting. So we will invite Paul back another time, but he was going to talk to us about a national picture from a mental health perspective. He is also a senior research leader and a mental health nurse, and he was going to talk through his research career and how we can help support other staff in across your organisation to develop their skills around research. But so we will invite Paul back another time. So I think that's come to the end of our webinar. Thank you for listening. I've put here our next webinar is I put query on the 3rd of June because we are just waiting for to whether somebody can come and attend. But again, it's on ward accreditation. If anybody wanted to scan this QR code on there as well, it's a survey about our webinar today. And if you want to review any of the previous webinars that you've attended as well, it just helps give us a bit of feedback. And Anthony, I don't know if you got any reflections on the webinar today?
No, I think it went really well. I think the key things and the take home is, for me, is about making sure that we bring the younger ones on board with us, be inclusive, be diverse when we are thinking of our research studies, to make sure that it's all inclusive and reach a wide audience as far as possible. But the most important thing is to ensure that we keep service users center of what we are doing, and that's the reason. Keep reminding ourselves that that's the reason why we are here. And I often say this as professionals, we sometimes need to not take the position of the professional, but to be curious and to learn from the people who we care for. I think that's really important.
Brilliant. And I say it a lot, but Anthony deserves an OBE or some sort of award. He's the absolute perfect clinical matron that encompasses research in the whole of the service that you run and everything else. So thank you so much,
I will pay you later. I will pay you later, Nicola.
You don't have to pay me. But yeah, so thank you everybody for presenting today. Honestly, really, really interesting. And yeah, as I said, the recording will be put on our YouTube channel, and I will send out the slides. So, okay, we'll see you in June. Thank you very much.
Thank you.